No, I don't know. Oh, it's not on. Okay. Everybody. Okay, yeah, it's ready. Okay, so to start, what are uterine fibroids? So uterine fibroids are benign tumors of the myometrium in the uterus, and they affect between 20 and 40% of women of reproductive age, and up to 70 to 80% of women by the age of 50. So they are the most prevalent type of gynecological tumor that occurs in the uterus, and on average, they increase 20 to 30% annually in premenopausal women. In the US alone, they are the leading cause of hysterectomy, and they have an annual cost that is estimated to be up to $34.4 billion. So their clinical significance includes reproductive complications that are increased infertility, preterm birth, postpartum hemorrhage, miscarriage, and more. And their other adverse symptoms can include heavy menstrual bleeding, fatigue, anemia, abdominal protuberances, and bladder and bowel dysfunction. So fibropathogenesis begins with genetic drivers. So these act to transform myometrial stem cells into tumor-initiating cells. Hormone signaling is also involved, specifically progesterone and estrogen pathways, which play pivotal roles. And the growth mechanisms include extracellular matrix accumulation, angiogenesis, and cell proliferation. And growth modifiers can include hormonal environment and lifestyle and environmental factors. So this is a visual displaying fibroid pathogenesis. So it shows how a normal myometrial smooth muscle cell can transform into a fibroid-initiated smooth muscle cell through various drivers, and then how this can lead to proliferation, extracellular matrix accumulation, and ultimately a uterine fibroid. So the current treatments involve surgical treatments, which the most effective one is a hysterectomy, which is just the removal of a woman's uterus, but this compromises the future fertility of women, so it makes it not ideal for women of reproductive age. Additionally, myomectomies are another surgical option. These are just when the individual fibroids are removed, and they act to they preserve future fertility of the patient, but they have a really high rate of recurrence, which makes them not the best long-term option for many women. Pharmaceutical treatments are also an option, and these are often suggested prior to surgery, and they are used to manage the painful side effects that can occur due to uterine fibroids while still preserving fertility. Common treatments can include combined oral contraceptives, levonorgestrel releasing intrauterine systems, and selective progesterone receptor modulators. So my first intervention will be vitamin D. Vitamin D is generated when your skin interacts with sunlight, and its signaling is mediated by vitamin D receptors in the body, and these are located in the myometrium of the uterus as well. And it can modulate proliferation, apoptosis, DNA repair, and extracellular matrix growth through the activation of the vitamin D receptors. This is just a display of the different pathways that it can act on. And additionally, multiple studies have linked vitamin D with uterine fibroid size and its occurrences in vivo. My second intervention will be epigallocatechin gallate, or EGCG. This is the primary bioactive polyphenol that is present in green tea, and it has anti-proliferative, anti-angiogenic, and anti-fibrotic activities that can act on fibroids. And this diagram displays these in the fibrogenesis pathway, and it has demonstrated efficacy in the treatment of uterine fibroids in multiple in vivo and in vitro studies as well. So my rationale for the combination therapy includes that vitamin D and EGCG both target key pathways in fibroid pathogenesis, including the decrease of cell proliferation and increase in apoptosis, and the decrease in extracellular matrix deposition and fibrogenesis. Additionally, they both modulate overlapping signaling pathways, being hormonal signaling, estrogen receptors, progesterone receptors, and the transformational growth factor beta and fibrotic pathways. So combined use of these two interventions may produce synergistic effects through these complementary mechanisms. So my research gap is that current treatments have limited scope, side effects, and effects on fertility. And the individual effects of vitamin D and epigallocatechin gallate are well established, but there's limited research on their combined roles in the treatment of fibroids. And their synergistic and combined mechanisms remain unclear. Additionally, there is a lack of integrated in vitro and in vivo studies that can define the usefulness of this combined therapy. My purpose is to first understand the synergism that may exist between EGCG and vitamin D. Second, to provide a non-hormonal fertility-preserving treatment with increased efficacy. And third, to reduce reliance on surgical and pharmaceutical interventions. My specific aim one is to elucidate the in vitro combined mechanism of action of vitamin D and epigallocatechin gallate in the treatment of uterine fibroids. And my hypothesis is that the combination therapy will reduce cell proliferation, increase apoptosis, and decrease cellular matrix production in the uterine fibroid cells more effectively than any of the other treatment groups alone. My experimental design will involve an in vitro study design using cells obtained from premenopausal women that consent to that are undergoing elective hysterectomies for their uterine fibroids that consent to allow us to take them for this research. And then the cells or the tissue will be collected via myometrial biopsies, and the specific tissue that is collected will be human fibroid tissue and then normal myometrial cells. So the treatment groups will involve a control group, a vitamin D group, specifically 1 micromolar, and EGCG group, 100 millimolar, and then a combination group, which will include both vitamin D and EGCG. The time points taken, where outcomes will be taken, will be 24 hours, 48 hours, 72 hours, and 1 week. So this is just a visual showing you my treatment groups and how they will be divided into the 8 groups. So these are my treatment conditions. So the tissues will be cultured into Delbecque's modified Eagle medium with collagenase and antibiotics and serum, and this is just a growth culture that will promote the growth of the cells. And then they'll be maintained using the explant method at 37 degrees Celsius and 5% carbon dioxide, as this mimics the physiological conditions that the cells will be in the human body better. And then they'll be serum starved for 24 hours prior to the onset of treatment. So my outcome measures will involve first cell proliferation. This will be measured using the MTT assay. Then flow cytometry as well. Apoptosis, which will be measured using flow cytometry. Hormone expression, specifically estrogen receptors and progesterone receptors, using the qPCR and the Western blot. And then finally, extracellular matrix markers, specifically fibronectin and collagen type 1, using the Western blot. My anticipated results is that the combination treatment group will display decreased cell proliferation, increased apoptosis, reduced expression of estrogen receptors and progesterone receptors, and decreased expression of extracellular matrix proteins significantly when compared to the other groups. On to my specific aim 2. So my specific aim 2 is to examine the in vivo efficacy of combined vitamin D and EGCG treatment in women of reproductive age with uterine fibroids. So my hypothesis is that the combined therapy will reduce fibroid volume, serum hormone levels, and symptom severity more effectively in combination than either treatment alone with minimal adverse effects. My experimental design will involve a randomized control trial using double-blind measures with a placebo group, and the participants will be women between the ages of 18 and 40 with diagnosed uterine fibroids. Treatment groups will involve a vitamin D group, 50 micrograms daily, an EGCG group, which will receive 400 milligrams daily, and then a combination group, and then finally a control group that will just receive a cellulose capsule. My sample, to continue, the exclusions will include they cannot be using currently hormonal therapy, they cannot be pregnant, or using drugs that have adverse interactions with vitamin D, they cannot have a severe vitamin D deficiency or a liver or kidney disease. So my primary endpoints, I will be using transvaginal ultrasound to find fibroid volume at my time points, the UFSQOL questionnaire, which is for the uterine fibroid symptom and quality of life questionnaire to define symptom severity, and then I'll be using blood samples to find the serum biomarkers of these women at each of the time points for my outcomes. This is the UFSQOL. So this questionnaire uses it's 37 questions in total, and it measures symptom severity and then health-related quality of life. And each section is scored from 1 to 100. The questions are integrated throughout, and then the higher the score for the quality of life, the better, and the lower the score for the symptom severity, the better. The treatment timeline, so it will involve the initial intake appointment, then the start of treatment 30 days later, followed by a 3-month check-in, a 6-month check-in, a 9-month check-in, and then the end of treatment at 12 months, followed by a 1-month post-treatment follow-up, a 3-month post-treatment follow-up, and a 6-month post-treatment follow-up. My operational procedures will first be to obtain IRB approval for the study, then to recruit and screen the patients for eligibility, obtain informed consent from the participants, measure the initial outcomes, then administer treatments and measure the outcomes at 3, 6, 9, and 12 months, and then conduct the post-treatment follow-up, analyze data and draw conclusions, and finally to report findings and consider future research directions. My ethical considerations will be to first obtain IRB approval, as well as informed consent from each participant, and the study will be completed in compliance with the Declaration of Health. My limitations will include a variability in the baseline vitamin D levels of the participants, patient compliance with treatment, dietary and lifestyle differences between the participants, and the individual variability of fibroid growth that can occur between patients. So my anticipated results are that participants receiving the combined therapy are expected to demonstrate significant reduction in fibroid volume, improved symptom severity, and decreased levels or serum levels of estrogen and progesterone when compared with other groups. My implications, so overall this research has the potential benefits of reduction of fibroid growth, symptom improvement, preservation of fertility, and reduced reliance on the current surgical and pharmaceutical treatments. Additionally, future research should include larger trials with longer follow-up periods and a further investigation of fibrogenesis signaling pathways, as well as how EGCG and vitamin D act on these. And finally, to determine optimal dosing strategies for individuals. These are my references. My acknowledgements include God, Dr. Abraham, my advisor, and Dr. Salvatore, my CNHS faculty and peers, and my friends. Questions?
That word, ECGC. Say it again.
Epigallocatechin galley.
No, say it like it was impressive.
Epigallocatechin galley.
Okay, that was it. Thanks.
Can I ask a question? I have a question.
Yes.
So you said in the beginning that individually, the two treatments were effective. How efficacious were they? Were there percentages given or?
So the EGCG, they weren't very, the studies that have been done have not been very.
Yeah, that's why I asked.
Yeah, they have not been very.
Is this just people drinking green tea and filling out a survey, or
so
are these
some of them were
scientific
like
surveys?
diary based, and some of them, a lot of them, the ones that I looked at were like diary based, like daily diary to look at symptom severity. There hasn't been very many that have been like cohesive of like all of the effects that it has, or comparing it to vitamin D. It's just been looked at because it has that antioxidant property, antifibrotic property, anti-angiogenic property.
Okay, so what about the vitamin D?
Vitamin D has been, people that have decreased vitamin D levels or deficiencies in vitamin D, it has been associated with an uptick in uterine fibroid occurrence. So the thought is,
Do you know, like what the person?
I don't know exactly what the percentage is because it can vary, but I do know that there have been, like multiple studies that I've looked at displayed that women that had the lower serum levels.
Which begs me to ask the question, has any of this been tested in mice or lower animals that you would jump right into a human
So
study?
because it is a holistic, well, first I would
Which is
do
really my problem with
vitros.
counting, that's why I'm asking you, because many times holistic things are not
Yes.
scientifically based, and that's my concern.
Yes, so the goal would be to validate it using the in vitro assay, and I'm just using this to kind of, justify, is this a worthy path to go down? To see if the combination. of
Right, because some of this
work.
is very invasive, like some.
Well, people, like, the vitamin D supplement is something that would do.
No, the testing.
Oh,
Drawing
yes,
tissue
yes.
samples from
It is very
fibroids.
invasive, yes ma'am. Well, the tissue samples from the fibroids, so those would just be taken from
These are bad.
women that are receiving elective, so we would choose women that had been receiving an elective hysterectomy, and the myometrial biopsy would just be taken from that tissue, so that wouldn't involve them at all they have to do is to consent to give their uterus to the study. But I understand that some of the in vivo testing is a little bit invasive, but those are just the best ways to find those outcomes, so I do think there might be an issue
Like, could you
somewhat-
induce it, could it be induced in a mouse first and then be
Well-
checked that way before jumping to a human study, is basically what I'm asking.
Yeah, that's a good question. I'm not inducing the uterine fibroids into them. I'm just testing.
I know, but typically that's what's done, right? And several of the things we've been through even today, but where they induce a condition in
Right.
mice and then mimic the treatment to see if it
Mhm.
had any effect before going to humans. human study, am I right? I mean, just, the
Yeah.
hormone human studies. So I was just wondering, like, why your thought wasn't that, you know what I mean? But you're saying because it was not invasive.
I just, the treatment interventions, and the levels that I'm moving them at have been used in multiple in vivo studies that have already been done. But I do understand what you're saying, because, you know, if you're taking them together, then they could have more adverse effects.
Thank you.
Sorry, thank you so much. Thanks, Kami. And for our next speaker, she is a major in biology with concentration in medical sciences. She is from Plant City, Florida, and has been at SEU for 3 years. And while at SEU, think about who could be president of a lot of things. She is the president of SEMBA, the president of the Flora, and what else? President of. She's a TA for various science courses and a member of the PHSO course. And after graduation, she's all set and is planning to attend Lake Erie College of Osteopathic Medicine in the fall. Let's all welcome Madison Gray.
Hi everyone, I'm Maddie Gray, and today I'm going to be presenting my senior capstone to you on modulating ESR2 dependent inflammatory signaling in superficial peritoneal endometriosis using Tiger taps. I have no conflicts of interest to disclose at this time. So to begin, we will discuss what endometriosis is. This is a chronic gynecological condition in which tissue that is similar to that of the endometrium, which is the inner lining of the uterus, is found outside of the uterine cavity. This causes the development of painful lesions that are hormonally responsive, and a lesion is characterized by the presence of endometrial stroma and glands. These lesions can develop anywhere in the peritoneal cavity, which you can see here. They develop on the uterus, the fallopian tubes, and the peritoneal organs as well. And there are 3 types: endometriomas, which are lesions on the ovaries, superficial peritoneal endometriosis, and then deep infiltrating endometriosis. Approximately 1 in 10 women are affected by endometriosis, and this equates to about 190 million women worldwide with this condition. So the symptoms of this are pelvic pain, infertility, chronic fatigue, heavy menstrual bleeding, and intermenstrual bleeding. While the direct etiology of this disease is not known or well understood, some of the hypotheses for the development of endometriosis are retrograde menstruation, genetics, or developmental origin. As far as treatments go, there is no known cure for endometriosis, but typically symptom management is done using NSAIDs for pain, hormonal contraceptives to control estrogen levels, as well as laparoscopy, which is surgical removal of the lesions. However, there's a high likelihood of recurrence with the lesions in this case, and then a hysterectomy, which is the removal of the uterus. Yes, so endometriosis is characterized by a complex combination of cellular, hormonal, and inflammatory pathways. This is an estrogen-dependent condition. There is an increase in estrogenic activity, and you can see how all of these contribute to the proliferation and persistence of an endometrial lesion. And so because there is an increase in estrogen, there also is an increase in proliferation of the cells, as well as a decrease in apoptosis. So these cells are surviving. And this disease is also characterized by progesterone resistance. So because this is estrogen dependent, we need to understand the estrogen receptors. There are 2, estrogen receptor alpha and estrogen receptor beta. Estrogen receptor alpha is encoded for by the gene ESR1, and this drives endometrial proliferation in the follicular phase of a normal menstrual cycle. It also supports the progesterone receptor, and it controls the genes for a normal menstrual cycle. As far as for estrogen receptor beta, this is encoded for by ESR2, and this fine-tunes estrogen receptor alpha signaling, acting as a helper. It also helps to maintain normal tissue homeostasis. So this is to give you a little bit of background of what this looks like in endometriosis. In a healthy woman, there is a higher prevalence of estrogen receptor alpha rather than estrogen receptor beta, and this leads to the controlled proliferation and the shedding of the endometrium each cycle. And then, as you can see in women with endometriosis right here, the presence of estrogen receptor beta is 100 times higher than that of estrogen receptor alpha. This causes inflammation, particularly increased levels of the cytokine of the interleukin 1b, and also an increase in proliferation of the cells. So because this condition is estrogen dependent, and there is such an increase of estrogen receptor beta, we could look at a controlled, targeted approach for this, to target this issue. And this could be done using something like TIGR-TAS, which is tandem interspaced guide RNA genome editing. This is a programmable DNA targeting system that functionally is similar to CRISPR-Cas9, another DNA targeting system, but it is smaller, it's PAM independent, and it has a dual targeting for increased specificity. There are two components of TIGR-TAS. So first you have the TIGR array, which is a repeated DNA sequence. This is spacer A and spacer B that has an edge repeat and a loop repeat just for structure. And this is processed into a TIG RNA, which is your guide RNA. This is what you see right here. So if this is the target site of our gene, this is our guide RNA with spacer A and spacer B of your selected gene. And then this will bind to the DNA on both sides for increased specificity. And then DNA targeting and cutting of the DNA can occur. The other component of TIGR-TAS is the TIGR-associated protein, which is a TAS protein. And this binds to the TIG RNA and it forms something called a ribonucleotide protein complex, or an RNP. And this mediates, the TAS protein mediates DNA cleavage. Okay, this is a basic example of the TIGR-TAS mechanism. So in the beginning, you'll have your TAS protein and your TIGR guide RNA, or your TIG RNA, with your encoded gene. These combine to form the ribonucleotide protein complex, and then they will go through sequence-specific binding onto the gene that you are targeting. Here, the DNA will be cut, and then the cell will either repair itself naturally through the NHEJ pathway, or through HDR repair using a template that you input. So the gap in knowledge here is that we understand that endometriosis is characterized by a high prevalence of estrogen receptor beta, but the underlying molecular mechanisms of this are not well understood. There's limited efficacy in current treatments with a high rate of recurrence with things like laparoscopy, and none of these treatments target underlying molecular causes. The direct modulation of estrogen receptor activity using a targeted strategy is not something that has been explored in previous studies. So the purpose of my study would be to elucidate molecular mechanisms. This will help us define how estrogen receptor beta and inflammation drive the lesion proliferation and survival that we see in endometriosis. Then it will be to apply TIGR-TAS gene editing. This will help us to test whether the modulation of this receptor can reduce inflammation and proliferation of the lesions. And then this will help to further guide therapeutic strategies to inform targeted treatments for endometriosis rather than symptom relief. And to do this, I will be following two specific aims. My first aim is to determine whether TIGR-TAS mediated modulation of ESR2, the gene that encodes for estrogen receptor beta, reduces cytokine production, specifically IL-1 beta, and cell proliferation in superficial peritoneal endometriotic cells. My null hypothesis is that modulation of ESR2 will have no significant effect on inflammation and cell proliferation in endometrial stromal cells. So to begin with my methodology, I'll be using a cell model. This is an immortalized human endometrial stromal cell, or an HESC. These will be seeded into 96 well plates, and optimization will occur before the beginning of this experiment. The cells will be cultured depending on the instructions given to us by the provider. Then we will go on with our ESR2 modulation using TIGR-TAS. We will transfect the cells with TIGR-TAS plasmid that encodes for the ESR2 gene. And this will be delivered via a lipoplex that will be allowed to incubate for 24 to 48 hours. We will then confirm transfection by fluorescence microscopy, specifically using a green fluorescence protein that will be placed into the plasmid construct. So these are my experimental groups. We will start with our human endometrial stromal cell lines. We will have a healthy cell line and a diseased cell line. And then for our diseased cell line, this will be divided into two separate groups, the non-targeting estrogen or ESR2, which is our control, and then the targeting ESR2, which is our experiment. For the validation of targeting, we're going to measure the ESR2 expression using a qRT-PCR to confirm that our targeting was successful. To measure inflammation, we'll be particularly looking at IL-1 beta levels, and this will be quantified using something called a sandwich ELISA. And then we will measure proliferation using an MTT assay, which basically gives us a reflection of metabolic activity in the cells as an indicator of their growth and survival. And so my expected outcomes and analysis for AIM-1 would be that we would see a decrease in estrogen receptor beta due to successful targeting and the decrease in ESR2 expression. And then we will also see a decrease in IL-1 beta levels due to a decrease in estrogen receptor beta. And then proliferation will also be decreased because of the decrease in both of the former categories. And then this would mean our null hypothesis is not supported. For my specific AIM-2, we'd like to evaluate whether ESR2 modulation alters estrogen and progesterone responsiveness in human endometrial stromal cells. And my null hypothesis here is that modulation of ESR2 will not restore normal estrogen and progesterone responsiveness in endometrial stromal cells. For the methodology of this AIM, I will be using the same groups from my AIM-1 with a healthy cell line and a diseased cell line that has the targeted ESR2 and the non-targeted ESR2. These will be cultured into 6 well plates, and then a hormone treatment will be delivered directly to the media, but it will be dissolved in a solvent like DMSO. My 4 groups will be a group that receives estrogen, E2, P4, progesterone, and then a combination of the two. And then one group will receive just DMSO as a control. To measure hormone responsiveness, we will assess the amount of mRNA present in the media for the estrogen and progesterone responsive genes, specifically using our qRT-PCR again, and our targets will be the progesterone receptors and the estrogen receptors. Measurements will occur at 0, 24, 48, and 72 hours post-treatment. My expected outcomes and analysis for my AIM-2 is that we will see a return to baseline of estrogen and progesterone responsiveness after our targeting, and this will be due to an overall decrease in estrogen receptor beta activity. And this would mean that our null hypothesis is not supported. The implications of this study are that it could clarify how estrogen receptor beta contributes to inflammation, proliferation, and hormone resistance in endometriosis, and how Tiger-TAS-mediated modulation of ESR2 could serve as a novel targeted treatment for endometriosis. This also shifts the treatment focus from symptom management to a targeted strategy to address underlying molecular drivers of disease. And then future studies could be to validate this using 3D organoids to evaluate the safety, efficacy, and any off-target effects that could occur, and to evaluate ESR2 targeting with other treatments. For my acknowledgements, I'd like to acknowledge my Heavenly Father for everything that He's done for me. I'd like to acknowledge my advisor, Dr. Horton, for all of her help, Dr. Salvatore as well, the College of Natural Health Sciences, and my family and friends. These are my references. Thank you.
All ready. Any questions?
All right, Nani, I'm gonna ask you the same question. How did you, you said that you were gonna use the endometrial cells, how did you obtain the cells?
So these are something that can be purchased through a provider like Oxygen or any of these main markets that are used for cells and research.
Any other question? Okay, I'll ask the question.
Okay.
Alright, so talk to us about your Tiger-TAS. is very new. I know it's claimed to be very successful. Why do you think is that better? Apart from what you said, that it's independent, or explain that in further detail as to why it's better than CRISPR.
Okay, so Tiger Task has the potential to be scientifically more effective than CRISPR because it is smaller in nature, so it makes it easier for the cells to take up the material that you're inputting. It is also PAM independent, which if you don't know what PAM means, it's protospacer adjacent motive. And that means that in typical CRISPR targeting, whenever you're targeting a gene, you need a repeated sequence of nucleotides on either side of the gene in order to cut. And then if you don't have that repeated sequence, it's going to cause you to cut out a larger portion of the gene. So because Tiger Task kind of eliminates that by doing the dual targeting strategy with both sides of the DNA, it doesn't need a PAM sequence on either side, and this can cause it to be more specific. And the fact that it's smaller, there's a higher likelihood of the cells actually taking up your technology that you're putting into it.
Any other questions? 7 minutes. All right, well, there's no questions. Okay. Thank you, Maddie. Our next presenter is also, of course, a major in biology with concentration in veterinary medicine. She's from Lakeland, and has been at SEU for 4 years. While at SEU, very active, she's been a part of the Christian Veterinary Fellowship, part of the School of Honors, also in the Christian Veterinary Missions, and an Alpha Chi member. Upon graduation, she plans to gain more experience working in veterinary clinics before applying to vet school. Let's all welcome Rachel Southman.
Okay, hello everyone. My capstone presentation is entitled The Analgesic Potential of Kudzu Extract for Domestic Cats using the Feline Grimace Scale and Automated Image-Based Facial Analysis. Okay. So in the US, there are about 76.3 million pet cats, and an overwhelming majority of those will undergo surgery within their lifetime. So having effective pain management directly influences treatment outcomes and reduces the risk of developing chronic pain from those surgeries. Despite this, there's evidence that cats receive comparatively less analgesia following surgeries. So what makes feline pain management difficult? The 2 overarching factors are the determination of pain itself and when to intervene with analgesia, and then the metabolic limitations that are specific to cats that limit the treatments that are available. So cats do not overtly express signs of pain in the same way that other animals like dogs do. They have very subtle behavioral changes that are affected by the stressors that would be typical in an environment like a clinical setting. So these behavioral changes include things like mobility, posture, temperament, response to palpation, and feeding patterns. So these take longer to observe compared to facial indicators, which are less affected by environmental stressors. So they're more specific to pain, and they take a shorter amount of time to assess. So the general idea of using facial expressions as a way to measure pain in cats is that
this would be a cat in severe pain, this would be a cat in moderate pain, and this would be a cat in no pain. Grimace scales are used in veterinary medicine to quantify that pain and make diagnostic decisions of when to intervene, based solely on facial expressions. So the feline grimace scale was developed in 2019 to assess acute pain based on 5 different facial action units. It scores each of those 0 to 2, and then those scores are added up, and if it is a total score of 4 or more, that's when you would intervene because the cat is likely in moderate to severe pain. So the 5 facial action units are flattened ears, orbital tightening, muzzle tension, whisker position, and head position. So while the FGS is a validated way to assess acute pain in cats, there are still limitations, like with variability in FAUs, with especially muzzle tension and whisker position, and there's also some variability in inter-rater reliability, and it still needs to be generalized across different types of pain, different breeds, and different diseases. So automated pain recognition is a solution that would mitigate those limitations by using deep learning algorithms to assess pain in the same way that you would manually, but it would make pain assessment overall more standardized and reduce observer bias and variability, also reducing assessment time and making it more accessible for non-veterinary professionals. So an automated version of the FGS was produced in 2023. It's basically a smartphone app that you can upload an image of a cat to and it will give you a score. It uses convolutional neural networks, which are deep learning algorithms that are specialized in processing image-based and grid data. It generates 37 geometric descriptors that label the key facial landmarks of the cat, and then it'll end up giving you an FGS score. So once pain has been established, there are a number of options available, but NSAIDs are the most commonly used in veterinary medicine for the treatment of acute inflammatory pain. Despite this, they have their risks, like a significant risk of kidney failure, liver damage, or GI damage, among other things. And this is because of cat-specific drug metabolism. They have a severely limited capacity for hepatic glucuronidation, which is the main pathway that NSAIDs and other opioids and phenols are cleared. So these limitations narrow safe dosing ranges. They reduce the number of drugs that are usable, and they force a reliance on cat-specific data sets, which drives research initiatives into looking at other types of drugs to be used as complements and adjunct treatments to reduce the dosages of opioids and NSAIDs. So kudzu is a plant that is widely used in traditional Chinese medicine for the treatment of inflammatory pain. It's severely invasive to the southeastern United States, where it contributes to significant agricultural damage and biodiversity loss. Puarin is an isoflavone that is extracted from the root of kudzu. It has exhibited anti-inflammatory and antioxidant properties in animal studies where it downregulates pro-inflammatory mediators. However, there are no feline-specific data sets for puarin. So my central objective is to explore the potential of kudzu extract in altering the pain-associated facial expressions in cats using the FGS scoring. So my hypothesis would be that the cats receiving the kudzu extract would have lower FGS scores, indicating a reduction in pain-associated facial expressions. So for my treatment groups, I'll have 3 different experimental groups with different puarin dosages. My control groups will be a positive control with meloxicam, a negative control with no treatment, and a placebo group with methyl cellulose. Each group will have 5 cats, and I'll be using a Callan-induced inflammatory paw model, which produces a 4 to 5 day inflammatory pain response. So my population will be 35 healthy young adult domestic short hair research colony cats. I'll be excluding anything that would affect FGS scoring, like brachycephalic breeds, cats with major facial pathology, or those with chronic pain. The cats will be housed in well-lit individual cages. each with a camera attached to the cage, and they'll each be assigned a non-veterinary professional observer that will do their FGS scoring. So my specific aim 1 is to quantify the changes in feline facial pain markers following the administration of the purine using the FGS. And the null hypothesis is that there would be no significant difference between the FGS scores between those administered the purine and those of the placebo and control groups. We'll have the cats a week prior to pain induction so that they can get acclimated to the space and reduce stress. And then 96 hours before injection of the Catalin, we'll start FGS scoring. And then after 5 hours post-Catalin, we'll do our treatment groups and then continue with FGS scoring over the course of 96 hours at these endpoints. This is an example of what an observer would fill out with the time points over here and the facial attributes over there. And this is what we would expect generally. We would expect low scores pre-Catalin, pre-pain induction. The score should be 0 to 1 with limited variability. And then post-Catalin, we would expect that the FGS scores would rise 4 to 5 hours as it starts to work. And then we should see a reduction in FGS scores for every group but the placebo and no treatment group. So the expected impact of this is to provide a foundation to further explore the use of purine as an adjunct treatment, allowing for lower NSAID or opioid doses. And we would expect that the null hypothesis would not be supported, and there would be a statistically significant difference between the FGS scores of experimental groups and control groups. My aim 2 is to compare the manual FGS scoring with the automated image-based scoring. We would expect the null hypothesis would be that there is no significant difference between the manual and image-based analysis. So we'll have cameras recording continuously each of the cats parallel to the methodology of AIM-1. Once AIM-1 has been conducted, we'll have 5-minute recordings from each of the manual time points that they were assessed. And then we'll extract images from those, and those will be scored with the automated FGS. So we would expect the same general trends as the AIM-1 results, with low FGS scores prior to pain induction, and then a rise and fall for every group but the placebo and no treatment group. So the automated FGS scoring would provide a standardized way to eliminate bias and make expert scoring accessible for non-experts. We would think that the null hypothesis would be supported, as there would be no significant difference between the manual FGS scores on the top here and the automated version of the FGS scores. So my expected conclusion is that the cats receiving the kudzu extract will have lower FGS scores, and therefore they will have lower pain-associated facial expressions. For future studies, we would look at more cost-effective ways of processing and producing the purine, better delivery mechanisms for it, and then, of course, more on the safety profile of purine. These are my references and acknowledgements. Questions?
All right, cat lovers. Questions? Yes.
I guess my question is, we have a non-veterinary observer fill out the pain score.
Mm-hmm. So that would be to make, it's important for non-veterinary professionals to be able to do it for post-surgical monitoring, like when a caregiver is taking their cat home. So it would be to validate that scoring for people that haven't received as much training.
Anything else?
So you mentioned that kudzu is like an invasive plant and it's all over the southeast US, but how would it actually be harvested for the purine to be produced?
Yeah, logistically, it's not, we don't have the infrastructure in the United States because most of the purine is imported from Asia. So, and it's also a noxious weed, so it's treated with a lot of herbicides. So some sort of system would need to be set up where we know for sure there are large groups of kudzu that aren't being treated with herbicides.
I'll ask the question. Okay, let's talk about purine. So how exactly is the mechanism of purine able to ease the pain, essentially, right?
So it works similarly to NSAIDs in that it ultimately inhibits pro-inflammatory mediators like these ones. But it also modulates NRF2 signaling to reduce oxidative stress.
None? We're just clapping. We're ready to clap already. Okay, is it, yes? So if there's no questions?
So our final speaker is Michael Parsons. He's majoring in biology with a concentration in medical sciences. He's from Port Orange, Florida, and has been in SU for 4 years. While at SU, he's been part of the esports team. And after graduation, he plans on getting married and pursuing his PhD.
Hello. Hi guys, my name is Michael Parsons and my capstone is on scaffold units and the use of SCI repair. So a little bit of background. Spinal cord injuries happen all around the world, from either motor vehicle accidents, sporting injuries, to even just falling off a ladder. In the US alone, more than 18,000 new cases appear annually, while the current estimate of people living with this condition is up to 255 to 390,000. The mortality rate of spinal cord injuries is also relatively high, especially in lower income areas, due to secondary symptoms such as infections, respiratory complications, and osteoporosis, to just list a few. Abstract. Spinal cord injuries are multifaceted disorders requiring multiple fields of study to collaborate on them. Due to the complexity of these injuries, no overarching cure has been found. However, many therapeutics have been created in the attempt to assist people with these injuries. These injuries are life-changing events, at least due to the inability to use the area affected below the injury. This can lead to extended hospital visits, as well as copious amounts of money spent on these hospital visits. Recently, though, the use of biomaterial scaffolds in SCI therapy has had the potential to be a huge leap in the repairing of spinal cord injuries permanently in the future. So what are these current therapies? Types of therapies available range from surgical intervention to cell therapy and physical therapy for the surrounding areas, as well as drug therapy. The usage of surgical intervention has also been paired with a type of cell therapy involving a structure called a biomaterial scaffold. These scaffold units hold the key to repair of spinal cord, as well as the reacquisition of function below the site of injury. Over here, you can see some of these therapeutic strategies where biomaterials are right here, and then cell therapy is also here. This is kind of more leaning in the physical therapy section with some of the magnetic stimulation and electric stimulation. So biomaterial scaffolds. Biomaterial scaffolds consist of a 3D lattice-style structure that promotes cell growth, adhesion, differentiation in a desired area of injury. The current use cases for scaffold units range from cell and tissue growth to organ repair to bone defect repair and even nerve regeneration conduits. Up until recently, these structures have been single material based, such as collagen, agarose gel, or even lauric acid. More recent advances have shown that complementary scaffold units can provide a better microenvironment for regeneration to occur. And then over there is just some necessities for biomaterial scaffolds to be efficient. So they have to be biocompatible, that makes sense. They have to be able to combine with some sort of cell therapy, and then they have to be conductive in some way. So sourcing of stem cells. Along with the use of combinatory scaffold units, we will implement the usage of induced neuronal stem cells. These somatic cells will be acquired via tissue or blood donations, and then the INSs will be made by reprogramming the adult somatic cells with specific transcription factors, such as OCT4, SOX2, NanoG, and Len28. Somatic cells can be acquired through blood vessels or skin, and that's where it will be primarily acquired from. So our hypothesis. The implementation of biomaterial scaffolds with induced neuronal stem cells will help the neurons of the spinal cord regenerate faster and maintain function after regrowth. Our null hypothesis is obviously that the implementation of biomaterial scaffolds with these INSCs will not help the neurons of the spinal cord grow back faster, and there would be no maintaining of function. So groups in this experiment. We'll be using a total number of 20 rats, so 10 per each group. In the control group will consist of 10 male Wistar rats. These rats will not have anything done to them, so other control group. Then the same performance test will be performed on each set of rats, which we'll get to in a second. The results will then be compared and plotted graphically. And then for our experimental group, we will consist of 10 male Wistar rats as well. These will undergo the experimental procedure. Same test will be done, and then both group tests will be plotted graphically, and then we'll even implement some values from, oh my gosh, sorry guys, some literature values in order to broaden the scope of these results. So specific aims. Establishing a method of SCI repair via the implementation of combinatory biomaterial scaffolds containing induced neuronal stem cells. Methodology. So 10 rats will be used in the experimental group involving the combinatory scaffold units with the INSCs integrated into the matrix. The procedure will involve anesthetizing the rats with isoflurane, and then after being anesthetized, they will be placed on a heating pad in order to maintain body temperature. The skin around the T10 section of the spinal cord will be shaved and prepared for the contusion. The contusion device strikes the T10 vertebrae and then will be inspected surgically after. So this is a contusion device. You can put the rat there, and then the impact head will strike the T10 section of the vertebrae after being anesthetized. So after the surgical opening to view the damaged T10 vertebrae, within 24 hours, the spinal cord will be decompressed. Decompression in spinal cord injuries has been shown to improve the rate of recovery afterwards. Within the day, the scaffold unit will then be implanted into the site of injury, and then the rats will be monitored for up to 6 months with regular checkups and tests performed. This is just what a CT scan of what the T10 section should look like afterwards. Specific aims to testing both the functionality and efficacy of the repaired neurons in the area of incidence by testing behavioral and motor functions. The methodology 2. During the recovery phase of the rats, multiple tests will be performed to test how well the treated area is healed. The 2 primary tests that will be administered are the basal-BD resin hand and BBB, as well as a cognitive behavioral test. These 2 tests will then be reported and measured against the control group has had nothing done to it. This is what a BBB test would look like. It's a scoring plot of hind leg motor function over a period of time. Anticipated results. Based on previous studies, the results from this study should be promising as well. Due to the implementation of combinatory scaffold units with the INSCs integrated, it is believed that the result of this experiment will be higher than normal and could lead to a new direction that involves the building upon of this methodology. Future studies. Expanding on the study being done here, this is a very broad study that we're talking about, so expanding upon this and bringing more field of study into this as well in order to increase the depth of research. Experimentation with different combinations of material. So in my experiment, I'm proposing that we combine collagen and agarose gel in order to make in order for the biomaterial scaffold to be the best suited for that area. Implementation of other cells or drugs inside of the scaffold unit itself. This is obviously pretty big, because if you change this up, you could change the entire situation. So these are my references. Acknowledgements, I'd also like to thank God, my NHS professors, fiance, and my family and friends. Any questions?
Questions?
All right, I'm gonna ask one because I don't know if I just misunderstood what you were saying or just didn't understand something. Our weight is part of what the testing to make the stem cells, to take a somatic cell and have it undifferentiate and redifferentiate to a neuron?
Correct, and that actually has been done.
I was just gonna say, has that?
Yes, that has been done. So this is it has been done previously as well in multiple studies actually, and that's why we're just able to implement it into here. We already have the
And were they implanted then into someone?
So the differentiated neuron cells will actually be implanted into the scaffold units,
Right.
and then the scaffold units will be implanted in the site of injury.
Have they done that at all anywhere?
From what I've read, I've seen 1 or 2 studies that have tried that, and it showed promising results.
Very interested, I have spinal cord damage.
So you're saying you're gonna get a neuron, put it on your scaffold, and you're proposing an agarose with collagen combination.
Correct.
To proliferate your neuronal cells and repair the damage.
Correct.
How is your neuronal cell gonna make another neuronal cell?
Well, we'll have multiple neuronal cells in there, and
Because neuronal cells are not undergoing mitosis.
Exactly.
We know that. So how are you gonna repair that when your cells are not gonna be able to proliferate?
correct. So we're putting multiple neuronal cells in there in order for them to for the scaffold unit to kind of act as a mediator and a connective tissue.
So you just.
But it's not
So
proliferating.
you're actually
That's
not
the
trying
thing.
to proliferate them, you're trying to get them connect to the neuron, the other
You want it to,
synapses,
yes,
right?
you're not repairing, you're actually allowing the neurons
The new neuron.
to
bridge the gap.
reconnect with the existing already there, because you can never proliferate those. That's the thing. Like, that's why we never repair neuronal injuries, because neuronal cells don't undergo mitosis. Like, that's already a given thing.
But they do repair, they do have.
Yeah, but they
do
can't
have-
make another one. Yeah,
No,
they
no,
don't
yeah.
repair. Yeah, that's the whole point, right? And so the repair is like, I'm not like following it. So what are, and I know you're designing, right? You're designing your neuron to be functional. So why do you have so many transcription factors? What are those for?
I was just those are just some of the ones that currently have been used in order to induce neuronal stem cells. So
For what? That's just a question, right? Because if you induce them, because they can never really become another cell, like what's the transcription factor for? Like what is it doing exactly?
well, it's so you have your somatic cell, and you apply the transcription factor to it that induces it to transform.
But you are not
To
doing somatic.
redifferentiate
Into a
to
neuron.
become a neuronal cell.
Correct.
So that's what the transcription factor is actually doing.
That's why I don't understand. At first it was neuronal, so now you're doing somatic. You're not actually doing neuronal.
No, you're taking a somatic cell, you're undifferentiating it, and then you're using the transcription factors to redifferentiate it into becoming a neuronal cell.
That's what I'm trying to ask him. Like, that's what, like, I'm confused, because the first is neuronal, so actually you're doing somatic. That's why I don't understand. Like, why will you guide a neuronal cell, so it's already a functional thing, with your new transcription factors? That
No,
doesn't make sense.
no, you're not, you're
Yeah,
dividing
so
the
you are
stem cells.
transforming your somatic cells,
Correct.
supposed to be, into a neuronal cell.
Correct.
So that being said, okay, what are these transcription factors that can actually, and what is their role? How does it become a neuron? Like from just
can
mere
do it.
somatic,
They can, I know they can do it with like, they can.
with
keep
other
doing it.
cells, but not
I've never
neuronal.
heard
That's why we have not repaired at all, even with, who's the famous actor with the cells?
Oh, yeah.
Yeah, the stem cells, that's what they're trying to do with him, and repair his brain cells, and they can never do it, right? And so this is like, that's why I'm so like, what are those? What does the SOX do? What does the NOG do, essentially?
Yeah.
To transform, what does it do?
No, that is a great question. So I don't necessarily have the answer to that because of the complexity of this field. We would have to at least implement like cellular molecular biologists, neurologists, cell therapists. We'd have to implement a lot of fields for this to really proliferate and become efficient because of the complexity of these injuries. So
That's what he said, it has been done in your studies, Michael, that's what I was asking.
Correct.
It has already been done.
What article is it? Because I have not seen anything that's actually already there.
Please, but I-
At this point, yes. It might be done for some other type of cells, but neuronal cells have never been shown successful when it comes to making it into a different.
That's my knowledge.
Yeah, that's what I have understood. And this is why it's been a challenge, right? And again, I'm not trying to say that was one of the key things that if you would have provided that, and what would okay, so for example, what can it do, right?
Yeah.
Possibly, so that there is a possibility of differentiation, right? Because that's what we're trying to do, is differentiate it and transform it into a functional nerve cell. So there's a lot of loopholes, I think, that need to be put in so that it becomes functional.
I have another question, but the other question is really just the more have you researched it at all? Have you seen any indications that Neuralink or companies like Neuralink would be able to bridge that gap?
So I haven't done,
part of
it is, no, it is. I
Right.
haven't done a ton of research on Neuralink. I've heard of it and I used to kind of keep up with it, but not previously. So I'm not sure on the development state of it. But Neuralink could for sure be implemented into something like this as well in order to
bypass it, where the
Exactly.
computer actually does the work of the
Exactly.
damaged neurons.
So that's a totally different story, because now you've got a computer program that actually takes up the function and then connects that function to actually existing neurons.
Correct.
So it's like out of the proliferation world. Yeah, you're not
Right,
making
right,
new things there. Yeah, so any other questions?
It's a very interesting topic.
Very interesting
Thank
topic,
you.
you just have to make sure that it's,
I have no idea what y'all are talking about, but I just double checked, but I do remember seeing a story not too long ago about them repairing the spinal cords of mice who had their spinal cords severed
for mice.
and allowing them to walk again.
Yeah, and again, that's
I don't know if
the,
that's much to do with this, but
repairing with a specific, whatever is your measure, and that's the whole point, right? If you can show that there is a specific measure of like what are the cells that you're putting in, like how, like this
I don't
is
know
an
any of
approach where you are differentiating cells to become another cell. Like you can, like we have a spinal injury hospital. We have those, like to actually like try to help, right? If you have spine injury, but not to make it to a new neuron. That's kind of the challenge on this, I think. Not the repair mechanism.
What made you choose
Yeah, what made you choose that? It's so
It
challenging.
is really
Like,
interesting.
I would not even, yeah, it's very interesting, but very challenging.
I just thought it was extremely interesting. When I was doing research on what I actually wanted to write about, it was pretty much like this is one of the first things that came up that I thought fascinated me the most. And I even actually had to change it from something else to this. It was something more with magnetic electro nanoparticles as well, but I kind of switched straight away from that field and went more for this route.
You should have put the nanoparticles in there as a mechanism instead. That would have been much better than making somatic cells into neuronal cells.
To be fair,
Yeah.
like just for personal use and nothing to appraise or anything. Send me the articles that you use. I would like to see the one where they undifferentiate and redifferentiate to a neuron.
Yeah.
Because I've never heard
Me either, yeah. Okay.
They teach it in my life.
I was about to say, we
We talk about it all the
induce,
time.
induce pluripotent cells. I didn't know about it with neurons, but
It
you can
to-
induce.
No, yeah. I know what happens with other cells. It's the neurons in
It's the
particular
neurons.
that.
I mean, again, we're talking about, yes, repairing cells, making cells proliferated. That's stem cells do that. But they have never done that with neuronal cells. That is the problem. It's not about the cells getting proliferated. Stem cell therapy is now a big deal.
Yeah,
Which is
even-
why
even
it's very important.
undifferentiating, like
The problem is the
undifferentiating,
neuron, yes.
redifferentiating,
The problem is the approach, right? Like, so, yeah.
Yeah.
Yeah.